Good afternoon, ladies and gentlemen. I invite you to have a listening to the challenges or gaps identified in Kasese and what we ought to do, and where you see another gap in formulation, I request you support us. This is Mbambu Agnes, the Senior Health Educator for Kasese. We looked at only 3 issues, and issue number 1 is the coordinated absenteeism, and DC are all stakeholders in supervision. And I think these are cross-cuts. Then action number 2, we said there needs a staff list to stigmatize clients due to current integration approach in health facilities. Remember, the Trump issue really worked on our service delivery, especially the HIV and TB services. So Ministry of Health came up with an approach, which is the integration approach, where you find we are doing like a one-stop center. And our health workers are providing all the services, because we can't say HIV services are to stop because maybe a bailer or partner X are pulled out and the HIV focal person. And this we shall pursue in 6 months. Then we said we shall also conduct trainings of peer support groups and VHTs about integrated service approach to create awareness among people living with HIV and TB. Still, the person responsible is me, the DHE, then the HIV focal person. Time frame is still 6 months. Another issue was inadequate staffing in health facilities. This is something we had discussed about, and we said, of course, this was with support of our COW. We said we need to lobby for wage bill and recruit required staffs at different health facility levels for better and timely service delivery. The person responsible is COW, and this will be pursued in 6 months. Members, previously there was a challenge that was raised in the presentation that I felt I should respond to because I got concerned, where clients reported to the CL monitors that they are not given enough medicine in health facilities. They are given little medicine and their return dates are frequent. To be honest, at times health workers do this intentionally because an HIV or a patient with TB is not supposed to stay for a long time in the community. This patient has to be monitored time and again. At times, health workers do it intentionally. 2, that patients with non-communicable diseases, especially those with hypertension, say they don't give them enough medicine. Medicine is never food. This is to the community, the CL monitors. Kindly let us clear this to our people, especially when we go back, because I notice you are part of our CSOs at community level. Medicine is never food. Medicine is given in doses. Let people know what is given to them is their dose. and let them follow the doctor's instruction. Any comment to this, to our presentation is most welcome. Dear, these 2 comments I gave because I was concerned. Any comment?
Yeah, thank you so much for the presentation. My comment is on action 1 for the coordinated absenteeism. The action is that you should submit, make an analysis compiled by the in-charge and submit to the CAO on monthly basis. So what happens if the results are showing that the person attended 8 days? Because the action should be comprehensive. So if you submit and it's only 8 days worked, yet they're supposed to be 15. So maybe we would add something there. Either we should hold a salary or something like that. I think that maybe would sound better than the in-charge just submitting, because the action is saying just submit. So he will submit and then keep quiet. Thank you.
Okay, thank you. Another one?
Yes.
You can note them down and then respond at once.
Okay.
Thank you very much. On the issue of stigmatized clients due to current integration approach in health facilities, on the action point, I see this action point. Yes, we work on stigma to this PHIV, people or TB or ETC. But this will also bring discrimination. Now what? Because stigma goes hand in hand with discrimination. Yes, we have this stigma, then there will be peer support group, what, but then these people that they are going to integrate us with, because I've witnessed these issues, I've gone some facilities, where they just mix. Now how are you going to work on that discrimination that is going to come from these other clients who have come to access other services? Thank you.
Okay, we are just taking one more and then she responds at once.
My comment that after we have submitted the staff list, maybe they should be forwarded for rewards and sanctions, so that these staffs are called and then maybe given warnings or talk to, maybe if they have some issues. You know, sometimes somebody can be absent when they have issues at home or other related issues. So if they can be able to be brought to the rewards and sanctions, then maybe they can improve on their attendance. Thank you.
I think, Agnes, these questions are not yours alone. We have a response from the CAO.
Let me quantify that reasoning we had aired out as Kasese. Obviously, when facts are submitted to CAO knows what to do thereafter. Those other integrities my friend is talking about is bestowed before to CAO. CAO will handle. From submission, CAO will handle. Thank you.
Yeah, thank you. You have any response, Agnes?
Thank you, Carl. That is the reason of going with your boss. He can save you anytime. Yes, that was, Carl has responded, and I thank you. Sorry?
My query is, CAO should tell us how is he going to handle it so that the community can know, other than seeing the same action being repeated by the same staff.
Let me put Thank you very much. You know, cow is a big person. Whatever comes to cow, cow knows what to do. So trust us as cows. If we can manage finance, we cannot manage disciplinary action. That's basically disciplinary action. And we are confident with the procedure. So be assured that when issues are reported to cow, cow has something to do. And how he does it is a lengthy process. We need not to discuss it from here. Maybe any other time we shall. Thank you very much.
Yeah. Thank you.
Thank you, Kasese team. Yes.
Thank you, Carl, and the member who raised the concern. And what I forgot to say, periodically we have dialogues also. And this is where we can give a feedback about what came out of the community and the actions of COW. Yes, that is after the Rewards and Sanctions Committee by COW. Yes. Then my sister asked about, now when you bring all the clients at one pharmacy, won't other clients stigmatize them more? Sister, what do you think? What would happen? Remember, we are all clients and we have gone to different consultation rooms. I don't know what happened to Dr. Bernard in his consultation room. I don't know what happened to Johnson, and we are all at pharmacy. What do you think would happen? Would there be stigma?
Because I think the issue takes us back to awareness on integration, because it is a new model. And each facility is doing it differently. Because we have facilities that had separate clinics and will keep operating without integration. But we have others that never had space that are going to do the integration. Because what is happening at the ISS clinic is not what is happening at AIC or at Nyamituobora or at a certain facility in Uchiro. In Uchiro, the books are different for this one of malaria and the files for these people who are receiving art. So they don't put them together. They sit like on the same table, but this client is receiving these ones for malaria and this one is receiving these ones for what? For HIV. So these people just even sit and wait to see this neighbor of mine is going to which person or which chair. Because we even found clients who just kept quiet and said, we are going to keep around until that person leaves. And that person did not leave, and that client didn't get treatment. I was saying, so I'm suggesting, if it is integration, there should be a separate room. They shouldn't sit like outside in the triage. They be inside. When I enter with my book, someone who has remained in the triage will not know what I'm going to do inside there. I move out with my drugs and go. But some just bring them, these ones are here, these RVs are here, then this one is given this, then this one is given ARVs. It is bringing a lot of stigma.
Thank you so much. My sister clearly said self-stigma. Thank you very much. Self-stigma is always within that very person. So it is good you also complimented our suggestion to continuously sensitize through the expert clients, the peer educators, the VHTs, and of course even the health workers. Because how do you think expert clients became expert clients? How did they? So, no, we shall see what to do, and we shall continue with those strategies till we reach there, because this is the beginning. I am happy for the findings because they have opened our eyes. So, day by day, we shall reach there as we continue to review what we have suggested.
Okay. Thank you, Kasese team. The final, give her to give the final. Just 1 minute.
Okay, thank you so much, and thank you, Madam Agnes, and our fellow Madam. Okay, sincerely, to add on more light, this method of integration, Madam, it would be the best, and it is the best. But only that, as I've said it, that clients have self-stigma. It is true. Most of them, they just know that because they have been coming to the facility to pick ARVs, they just know it within them that maybe everybody knows that they are sick. But this integration has worked upon it in a smart way. Because as we are here, we are all here in one room. Who knows that I'm sick or you're not sick? Nobody. So it is the same. We just join at the reception. From there, you enter in the clinic one by one. There's no method of carrying the file. It is no longer there. So the most important thing is to educate and sensitize our service users and clients so that they should know that this integration isn't a burden, but it is even a way of helping us. Because before you enter in a clinic where there is a TB, everybody knows that this room is TB. This room is for arts. But today, it is no longer the case. Thank you.
Yeah, thank you, team. Thanks, Kasese team. Let's go to Rubirizi team. Let's give a hand clap for Kasese team.
Thank you so much. Good afternoon once again. The Rubirizi team is there. We put our actions together. We looked at administrative and then service. So privacy, one is that given that the planning phase, we are in the planning phase, so that's why we are saying that we are going to ensure that during planning, facilities incorporate in the component of partitioning of the available space. And we hope that one will be done in the next financial year by the end of September. Linking CRM issues to the district leadership, as we discussed, we said that given the model, we are going to have this meeting with the TPC, whereby we are going to call the CRM implementers to give a presentation so that we can have the district leadership brought on board. Still, we are continuing to make sure that this presentation will be done in DEC and then other sector committees, such that some issues are picked and then handled at the district level. Still, as a district, we always have quarterly performance review meetings and every quarter. So we are saying that at least let's have two slides within that presentation that reflect the CLM outputs. Non-functionality of the CLM committee at the district level, it's part of the CLM functionality. So we have a committee, but we have agreed that we are going to have it operational and have at least some stakeholders from the community, not only having the technical team at the district. Then hindrances, we have seen that our CLM monitors, when they go to facilities, sometimes they have denied access by the facility in charges, and oftentimes in charges see them as auditors. So we are saying that we are going to formally, the the CBO is going to formally write to COW before they start the implementation of the CM activities, such that these monitors, when they go to facilities, they have at least a formal letter that is written on. Among CM service users and providers, one is that as a district, because of integration, we are going to make sure that we rely on the RD's airtime on the radio to sensitize the communities about their services, such that once they come to facilities, some of the issues like the integration and whatnot, they are really aware of them. Then I think my sister in Kasese concluded with strengthening health education and communication service users through community brothers, community dialogue meetings, and health facility-based health education and communication. I think those are some of the 5 actions that we are going to work on as a team from Lubirizi. If there is any addition, the team is there.
Let's give them a hand clap. Any comment for the team? 1 or 2. Then we can go to the next district.
Thank you, Team Lubirizi. Mine is just an inquiry, just to borrow from your ideas. When you talk of robbing for free airtime for to go to the radio and do the sensitization, how do you cover transport for the person who is going to go there, facilitation for the person who is going to go there? It's as if you look at just airtime, free airtime, then you don't consider transport and facilitation of the person who is going to go there. It may not be sustainable or more effective like if those were available. Thank you.
Okay, thank you.
Yeah, thank you so much. Of course, when we are planning, because we are much aware that we have that airtime, we always plan for an SDA, because for us we have a radio station within the district. And actually the radio station is not even, okay, we have 2 radio stations and they are not even a kilometer from the district. So it is affordable. What is very expensive is the airtime, but the SDA and transport really we can manage, because the airtime is given by the RDC. Thank you.
Okay.
Thank you so much, Team Lubirizi. But I'm looking at issues to do with community ownership, community engagement, because if we leave everything to the DHOs, COW, we are going to use up at the end of the day. Because us as a community, everything goes with responsibility. Because there are issues that are just weaknesses of either you is implementing or the community itself. And we have to also be responsible and work on some of the issues at community level. But if we just leave the things to these things, because when you say including, you mean you have not been including these people in your quarterly performance review meetings. So some of the issues as we go, as service users or some other people in the community are doing this, continue to also identify some weaknesses on your side. And if I can identify it as immaculate, what about this person who is injecting in some money? Let me stop there.
Okay, thank you so much. COW and DHO. May I answer, please? So, COW and DHO appearing, that doesn't mean that they are the ones going to do the work. Their role is coordination and being focal people. You get it? It doesn't mean that COW appearing there that is going to overlook CLM presentations to DEC. It doesn't mean that he's going to do it. It means that he's going to ensure Yes. Yes. Mm. Yes, please. Mm. Yeah, thank you. Thank you so much.
Because to you as a CPO, you don't have even to go and introduce all your work. And the monitor was selected by a community. The community that knows the car, the facility, the what, PHIV network. Me, actually, you give me like a
Thank you so much. Members, let's accept that districts are at different levels, okay? These are challenges for Rubirizi, okay? So accept that these are our challenges and that's what we are going to work on. So on our side, there have been weaknesses and we have acknowledged them. We are going to work on them. Thank you so much.
Okay, thank you so much once again. Zainab from Nakola. So I don't know if what I'm talking is a stray or it will come in the general conclusion. Adding on what my fellows has talked on how to protect the CLM monitors. We have heard it as if it is a general thing. It touches all the monitors all over, and I've been facing it in most cases at health facilities where there are in charges who are rich and who don't attend every day. Once you go there for a meeting and you miss other staffs who don't attend. So when you go there for CLM data collection and you find that he has come when you've started the work, they look at us in a bad way. Till then you explain. And even other staffs are there who are rigid and not cooperative. But for me, I was requesting it should be a general thing, not necessarily for the easy, as you are working upon how you protect. You should look at this, giving the monitors identifications, because when you go to the field or to the facility or collecting data, you should give us more weight, adding on our weight. When you reach there, when you have, let's say, a T-shirt written on CLM monitor, I don't know if it is the role of our CBOs or the donors. You should look on it, because sometimes we have questions. They question us, where are you coming from? Maybe you are in an area. They look at us in a different way, as if I've just come from the garden. So give us more weight. You can give us like either an ID or a T-shirt. When someone reads on the T-shirt, they'll say, yes, this person is also an important person. Thank you.
Yeah, thank you. We close the session.
Thank you very much. Then it means there is something that we missed at the beginning. Now, health facilities are also institutions on their own in the community. Then you are also implementers like other implementers who have come to the district and they are going to do some work in health facilities. So what I see as a missing link, yes, you've gone there at times. One, the way you present yourself is one. Then two, have you reached that health facility with an introductory letter? At times people have said, no, we are working with organization X and they go into health facilities. To be honest, they may not accept you. Come to DHO's office with your introductory letter. At times people go through COW, then to DHO, or move with somebody from DHO's office or move with an introductory letter, and the health facility is going to receive you well and work with you because the DHO has instructed them to work with you. At times, the DHO calls that I have sent this team and these are the intentions of their visit and this is what they are supposed to do. And you work with them very well. We have had several teams. One case in a point when we had emergencies, ministry teams would come as expert teams and just pump into community or health facilities. They were chased away. We again went to the drawing board at DHO's office, sent them back with introductory letters to health workers, and they worked with them very well. So it means there is a missing link that we have to bridge as a team. The team of the implementers, the CL monitors, the CSOs in our district, please come to our office and we bridge the gap. Otherwise, those health workers are the best and they have managed very many things. So, either communication, either self-stigma. So, let us bridge our gap. Thank you.
Thank you. Thank you. Let's go to
good evening, team. I'm called Javira Magaragario, and I'm a coordinator for CRM activities. When we look at the issues identified by Ruberi's team, like the CRM issues, linking CRM issues to the district, this is an implementation challenge. And here we should be discussing the issues mentioned by the communities. Like what I've been identifying in the reports is what we should be discussing. This being an implementation challenge, we can handle it at the district level. And I'd like to guide that let's stick to the issues identified by communities, like what we have been presenting in the report. Thank you.
we are going to Ntungamo team. Rwanda. Okay. Rwanda team. Let's give a hand clap to the Ruberi's team. Ntungamo team, yours is already there. After we shall have Rwanda team. It's all about that.
Okay, thank you. Good evening, everybody. As per the this is what Ntungamo team came up with. The Ntungamo team, you may put up your hands for recognition. I am just presenting what they documented, and according to what the monitors picked in the community, one of them was that there was low awareness and ineffective feedback mechanisms. Actually, as DHT, we didn't know that this one is there because we knew that our facilities have suggestion book says that almost on every facility there is a signpost showing what is offered in a facility, but the monitors in their interaction with the service receivers, they identified it. So we thought that maybe a number of people do not take time to read the signposts and understand. So we are suggesting that there should be community dialogues and good enough. Mayanja Memorial Hospital Foundation actually supports us in this area, but it has been concentrating in areas where there is more malaria. So we now think we are going to incorporate this element. We are basically dealing with malaria issues. We are now going to incorporate the element of awareness, especially on the services, and how the community can give feedback to the facility. We are giving it to health educators and the VHTs, and this should be an ongoing activity. Whether Mayanja is supporting or not, whenever there is an opportunity, our VHTs should do that. Then, in their movement, they found there is a shortage of sanitation facilities, especially toilet facilities, and this one was an issue. The DHO is aware, the cow was aware, but the issue was on resources. We are saying that now, in the next financial year, 26-27, as they are planning and doing their budget, the little money that will be available should be put, they should prioritize sanitation services. Otherwise, we saw it as a very dangerous thing. There is this gap of long waiting time. Of course, we know that one normally, it has a relationship with inadequate staffing and staff accommodation. One, as someone mentioned, when we look at the new staffing structure, Ntungam is actually at around 31%. That shows that you can see we are not even somewhere near 50%. But again, accommodation facilities are also not there. So health workers travel. Actually, majority tend now to stay in the urban areas. So in the morning, they move, they travel to the facility. Automatically, that one means that they can't reach early, and they also have to leave early their workplaces. So it is an issue which is triggered by other factors. But we said, okay, the COW and the DHO, of course, are going to enforce reporting and departure time, and of course, through support supervision, possibly there can be an improvement, and this one is an ongoing activity. Another issue was on inadequate supplies in some facilities. Yes, of course, most of our facilities get a standard kit where we don't determine how much should come or what we need. But we say some we find they have more, others they have less, because for us now we can't adjust that kit. If the ministry official was still here, he would actually take this issue to the ministry, and it reaches NMS that the standard kit is an issue, that it should allow every facility to order according to its budget and what it needs. But meanwhile, we said, okay, the district should do redistribution of the supplies. It picks where there are a lot and puts where there is a need. And this should be spearheaded by facility in charges, by declaring a need and declaring overstocks for some facilities. This one is also a continuous activity. They also realized that there was an issue of poor communication and the attitude of our health workers. This one has been a song for so long. The solution is not yet there. Someone suggested that we can train in customer care. I know in Ntungam we have ever had it. but it is still there. Another one suggested rewarding exemplary personnel. But I know at the end of every year, we normally have a staff party for all health workers, and we also reward the best performers. So the issue of attitude and the communication, it is also related with staffing. When one works from 80, by 4 when you come and you find he's already tired, the communication kind of changes. So it is an area where we all need to put some effort and see what to do. But meanwhile, we shall continue. Of course, if we happen to get an opportunity, we shall have to continue training them in good customer care, good communication. The good ones will really change. And we say the DHO should take on this, and this should be annual. Stigma and discrimination is indeed a big challenge. I had the Kasese team concentrating on it, but that one is there, and actually even us, we thought by integrating services now that the business of specific clinics is no longer there, we thought it may possibly now be minimized, because now you will be, if you are HIV, TB or what, you will be with malaria, the diabetes, the what, you will all be together, each one of you will be entering his own room. But of course, we can't stop there. We have to continue sensitizing the community that being sick is for everybody. Such that when you are sick, you'll be satisfied and seek help. We say the DHE should take on this one, especially in community dialogues, on the radio. We are like our RDC also gives us some airtime. For him, he has a schedule, this time for education, this time for health, this time for community, this time for agriculture. So, when there is that opportunity, we shall continue still sensitizing our communities. And lastly, inadequate staffing and of course staff accommodation. For us, we raised the issues that were picked by monitors, and some we don't have a solution for them, especially on staffing gaps and accommodation. When we triggered our cow to write, he said that they have written several times, but they have always received the negative feedback. So, of course, we shall keep preaching the gospel. If we have people who can reach the ministry and some who can reach the president, you should tell him that unless he increase on staffing, health services may not really improve greatly. I thank you very much for listening.
Any comments for the team? Yes. One or two.
Thank you very much, Ntungamo Group. Me is specifically on the health workers' attitude and communication skills, considering on their institutional ethics. That way forward of rewarding the exemplary personnel, I don't know whether you are rewarding the person who have performed better or you are rewarding the person who have been performing poorly at the end of the year. Because if you reward the person who have been performing better, there is no way out is going to bring out those who are performing badly. It is a habit for almost all over the districts. They will have end of year parties and they reward the best performers. What about the worst performers? Because they also know them from the suggestion boxes, from the community dialogues. How are you working upon them such that we can also copy from you? Thank you.
Okay, thank you. Another one? Machiritinda kuichirize hati.
Thank you so much. I'm called Moses Nohari Chimanya. On the issue of long waiting time, you said you enforce and supervise, but remember some facilities will receive patients having different kinds of diseases. There are those who wait for the results. So I think you need also to inform the patients that every patient, some patients have to wait for their results from lab, others, because they are different kinds of patients. Thank you.
Okay, thank you for those comments and thank you, Ntungamo team. Let's give them a hand clap.
Hey, they asked whether we are rewarding. Thank you for that supplement. Of course, as you mentioned, waiting at a facility depends on the conditions that you have. Our work is to at least make sure that we give you all the services that you need. So that one was a good supplement. On the issue of rewarding, we have been rewarding good performers, trying to encourage the poor ones to change. I don't know the view of other people whether you can reward a poor performer to continue performing poorly. That really, I don't know. We can get views from other people. Thank you.
Thank you, Ntungamo team. Let's add them a hand clap. Okay, let's welcome Rwanda team.
Thank you, Timos. I'm Bruno Tumshave, representing Rwanda District. I would love to request my team to wave to the congregation so that they are seen. That is Rwanda team. Thank you. Following the district level meeting we had on 19th of December 2025, we were left with 3 unresolved issues as displayed there. We realized that the Mukwa Center 4, which is now a general hospital, is still receiving medicine and supplies for a health center 4. So while we were seated there, our cow gave us blessings that he's going to follow it up by writing to MOH so that kit is revised going forward. And we have given ourselves by end of Feb 2026. This letter should have been written and forwarded to MOH. Then there was an issue that was coming up from the facilities where these guys went, especially these hard-to-reach facilities. We have Ruhija Center 3 and Gindi. Ruhija Center 3 is just after, it is through Gindi impenetrable forest. We realized that the mothers and other emergency cases were getting difficulties in accessing health services such as C-sections, those services that need to be referred. So we have sat down as a district. We have done a centralized coordinated system where each facility allocates 5% and 5% of their PHC to referral system, referring the emergencies. And that has been done and has been given the blessings of the council. We have the work plans approved. If you came to the district, you'll get them there. Then the other issue that we have taken up is the poor and the unstable electricity. We realized that Bufundi, which is Area Center 3 and Mpung, they have inconsistent power supply, much as they are connected to the national grid. So we, as a district, we have positioned ourselves to include the solar power supply in this, since we are already in the planning and budgeting cycle. So we intend to take that up because the budgeting and the planning is moving forward. Of course, away from the other issues that came in the report, we are related to no male ward at the general hospital simply because the hospital has not yet been finalized as far as construction is concerned. We have lack of inpatient ward for males, then the mortuary. So once the hospital has been finalized in terms of construction, all that will be addressed. Otherwise, thank you so much for your audience. I will welcome the comments, the reactions, questions. Thank you.
Thank you, Rwanda team. Let's have comments for the team. 1 or 2. Yes? Okay. Okay. Rwanda team has presented very well. Let's give them a hand clap. They don't have any questions. Thank you. Let's have Mbara City. Mbara is the one closing.
Good afternoon, everyone. Other teams, apart from Mbara City team, wave for me. Other teams, wave for me. Other teams, wave for me. Thank you. This is a work plan for Mbara City, action plan, I mean, for Mbara City. Of course, all the challenges that are highlighted in this action plan are all guided by the data we collected. We didn't think about them from here. These are all guided and justified by the data we collected. So area number 1 is on community and system issues. Long waiting hours, and which we attributed to understaffing, guided by the data we collected. And there we are also highlighting that Mbara City is at 22%, which is very, very low, given our sister Isinjiro is at 70+%. And our action on that, we're saying that we are going to support and to ensure that we lobby for wage from Ministry of Health and Public Services. And this will be through the city mayor and city town clerk. And at that level, we felt like they would be in position to enact something tangible. And the time frame for this, we are giving it up to the end of the financial year. Then the second issue, under the same area, community and system issues, is lack of awareness of new service delivery approaches, stigma, and service packages. And here we are saying our action on this is going to be community sensitization on issues on new service delivery approaches and service packages, including integration. And we shall also support and push for collaborating with existing structures like VHTs and CHOs, especially attached to the facilities, then the like-minded CSOs, to ensure that information reaches the community. And in this, the person responsible is going to be the office of the CHO, including the city health office educator, and also the in-charges for the facilities we are supporting under CLM. And the time frame, this is going to be immediate. And issue number 3, under the same area of community and system issues, poor attitude of some health workers. And in this, we are saying that health workers need to be taken through customer care sessions and follow ethical code of conduct, and this will be done through CMEs. And these will be, the person responsible will be the in-charges for the facilities we are supporting under CLM, and also the city health educator, and this is immediate. Then another area is on infrastructure, and the challenge here is limited power supply at Nyakayejo Health Center 3 health facility. Nyakayejo Health Center 3 has been renovated of recent. There are some new structures that have been put in place, but one block is the one that has power, and other blocks don't have power, including the Yakakanajishashura Tonjira Shija. So we are saying that Nyakayejo Health Center 3 has new blocks in place, but only one block is the one that has power. The OPD doesn't have power, even the staff quarters, they don't have power. So we are saying that we are going to ensure that we support extension of electricity from MCH building to OPD building, and this specifically is going to be the person responsible is going to be the CHO, the office of the CHO, then the senior medical officer and the city planner. However, on this very issue, this action point has not been entirely developed by us. This action point was developed during the feedback meeting with the city, and the city planner, the CHO and the CMO are the ones that committed themselves that they will take this up and ensure that they support the facility to ensure that they have power for all buildings. And timeline, we are giving it to the end of financial year. Then second is the poor sanitation at some health facilities. And the action point here is construction of enough washrooms, all toilets, ningala twinzi, echumana chete ni checho, to handle the number of clients at MMC Health Center 4. That is our Health Center 4 here. And the responsible persons, the CHO, then and also the SMO, including also the city planner. And we are giving it the timeline up to the end of this financial year. And still under the same area of sanitation at some health facilities, Ruti Health Center 2 doesn't have someone to clean the toilets, the washrooms, and clients have been complaining on this, and we also want to see how we can advocate for hiring of a cleaner for washrooms at Ruti Health Center 2, and this is going to be immediate. Then another area is the quality of care. Then the first challenge is lack of privacy in bracket dispensary and lab spaces. Around those spaces, privacy is not there. And during the discussion we had from morning, there is one colleague who shared a new model, and we decided to tap into that and see how we can advocate for it and push to see how we can also adapt it. We are saying that our facilities have limited spaces. The spaces are very small. Look at Nyamchobara Health Center 2, Ruti Health Center 2, even in Kamukuzi Health Center 2. The spaces are very small, even Kakoba itself. But we are saying that we want to ensure there is a proper utilization of those limited spaces. where we are going to support or to push for facilities to have meetings on how they can rearrange the client flow chart so that those spaces are proper utilization in respect of privacy, and also adapt the new model we borrowed from one of you who shared it in the morning, the model of dispensary rooms instead of dispensary windows, and at all the facilities. Then the second one is limited support for integrated community interventions, including follow-ups for back to care and PrEP refills. And here we are saying that we are going to have the facilities to encourage VHTs and choose attached to these facilities to support continuity of service delivery. But we felt that that alone is not enough, given the fact that initially we used to have the peers who are no longer there. But here we are taking advantage of the available opportunities. That's why we are tapping into the choose that the Minister of Health has put in place, and also the VHTs that are available, especially those who are attached to the facilities, but also tap into opportunities that are provided by the IPs. JCRC is also providing some opportunities we can tap into here in Imbara. Then, and also we have like-minded CSOs and BICs that would also support on continuity of service delivery. In this case, we all appreciated that there is a new normal. This new normal is not going away. There are some things that will never come back. But what is available, what opportunity do we have that is available that we can tap into and we ensure that service delivery continues? And the person who is in charge is going to be the CHO, and the in-charges for facilities we are targeting. And we are saying this is continuous. It's going to start and it has to continue. Then the last area is availability of commodities, where we had the challenge of commodity stockouts. And we are saying that we are going to ensure there is proper ordering and commodity redistribution from facilities that have stock to the ones that are stock out. And the persons in charge is the office of the CHO and the facility in charges. And this will be continuous. Thank you.
Thank you, Mbara City team. Let's give them a hand clap. Yes, one or two comments for the team. Yes. Okay. Mbara City team, thank you for presenting. We have no comments for you. Let's invite Isinjiro team. As the Isinjiro team finishes, we shall have comments and remarks from our Executive Director, Dr. Mayanja, and then we can have the closing remarks from the cow Kasese.
Good evening, everyone. We are all asleep. I'm going to present for Isinjiro the gaps that have been issued. We identified that there is poor road network between Chitiaza and Ruwondo Health Center too, and this limits the access to the facility by the clients, especially the pregnant mothers. I think Dr. Bernard has been there before. You've tested the roads, you've seen them. Those roads are very poor. We are not looking at only pregnant mothers. Now you imagine a mother from theater passing through those potholes. It is really a very big issue, and the action that we've taken is advocacy at the the cow, we involve in the cow, the UNHCR, since that road takes to the refugee camp for grading of the roads. And this will be done. We are going to advocate, and maybe we request them, at least if they cannot tarmac the road, given that there are many very many partners, they can at least give in money for fuel. They clear those roads once in a while so that our mothers don't face those problems. And the one responsible will be the cow. And the time frame we've given it is end of March 2026 during the district coordination meetings. Then we also identified that pregnant mothers share beds with male patients. A case in point, there is a facility, personally I attend to, that is Mayanja Health Center 3, where I found a case. Maybe male patients come in, sickness has no time. Someone falls sick and they are bad off maybe in the evening. And the fact that there is no IPD, they cannot admit. The only place that has beds is the maternity ward. And what do? Just to give the patient bed rest. You find male are mixed with female, kids are mixed. There is no isolation and no privacy. So it is the action that has been taken, or that we shall take, it's in the 5 years development plan to construct the IPD ward for Mayanja Health Center 3, and that will be followed up by the DHO of our district, time frame 2026 to 2027. We also identified that specifically at Chirumba Health Center 3, we also have poor infrastructure where we do not have the staff quarters. And this brings, there is the way it delays the services, or some patients are denied services. For instance, during night shifts, trust me, a nurse won't sleep on ward unless they are on duty, and they do not have actually the ward where they can sleep. There is only one room, and it was specifically given to midwives, just in case a pregnant mother comes. But people who come in with serious cases at night, they do not have where to be put. They also do not have the IPD. And that the action taken, it's in the 5 years time development plan to construct for staff quarters and IPD department at Chirumba Health Center 3. And that will be followed up by the DHO of our district, then that in the financial year of 2026 to 2027. Then we also have a problem with language barrier, especially for facilities that are located in the settlement. An example, in case people do not know, there are many countries that are there. You find you only know Kiswahili or Kinyarwanda or Runyankwe, and we have Ethiopians, we have Somalis, we have Sudanese. So our engagement with them, we do not really give the full package to them, and neither do they give us a full package, and which leads to failure to identify the problems of the specific people in that area. So the action taken will be advocacy with Mayanja about provision of translators, with data collection, especially for facilities in the refugee camp. The fact that we've mentioned Mayanja, so people responsible, the organization DOP as a CBO, and Mayanja Memorial Foundations, I think they will attend on that. And I think that will be by the next semester, in order to give quality data. Then another problem is there is no visibility of us as CLM monitors. Yes, Mr. Javira said that we shouldn't point it as a problem, but yes, it is. Because the whole point of CLM, it is we ask, we receive, and we give feedback. So if people chased me before I communicated, I would not know the problems. You're getting my point? Or if people did not realize how big I would be or how much I present a certain group, they don't open up. They will think either I'm policing them. I got a case instead. I got a problem where I was talking to some people in a place called Kamuri, and they were like, "Don't tell me of these organizations that come and, they just want to grab information from us and they want to use it to build their own, So that one is a problem. It might be looked at as a problem of CLM monitors, but it is actually a big problem that hinders data collection. Hence, we bring fake data. Someone will give you what they are not supposed to speak. They can give you fake data. So the action taken is the DEOP department will advocate for visibility budget with Mayanja provide the operator. It is a little bit questionable. And most of the time, this service is so important on the facility, because look at a mother who comes in at the facility at midnight and she's taken back to look for the scan results, because there is no midwife that is ready to attend to you, because she has to follow all the protocol, minus any results. What if the baby is in bleach and she cannot, tell? So I feel it is also very important. And the action taken, the thing is, the ultrasound scan is there, but the person operating it is not there. So the action taken will be like, we shall advocate for the resource, for human resource, that is someone to operate the scan. They have not given the exact time. So we shall continue advocating, but I feel the person responsible should be the DHO. Yes, thank you so much.
Okay, thank you, Isinjiro team. Let's give them a hand clap. Thank you, Isinjiro team.
Any questions? Any contributions?
Yes, let's have comments for the team.
I just wanted to add on the source of the data or issues identified. Those are the key issues we picked out from the reports we do submit. There are many issues, but we felt those were more critical, and how we reached at those issues, picked up those 7 key issues. Thank you.
Okay, let's get 1 or 2 comments from the team.
Thank you very much. But ma'am, I'm still sticking on the issue of the CLM monitors. This issue of keeping on saying that they are chasing the monitors. Go back and clean your houses. Because it was clearly stated that the CLM monitor should be from the community, even selected by the community. And these facilities are also part of the what? Of the community. But now if you say they are chasing you, that language I'm not understanding. Maybe you should work on your relationships, communication, those things.
Maybe to give clarity about that issue, yes, we are from that community, but a reminder, I can be from Rekubo, but I'm given at least 5 facilities, whereby the other 3 are in a distance from me. And another thing of other organizations have, should I say, they have made dirty over name of other organizations, because there are some other people that come and tarnish the names of organizations. Yes, clearing the name is good, but in the first place, how will I clear the name? Yes, I'm the monitor. I'm in the community. Maybe I'm from Rekubo, but I'm attending to people in Nshunjerezi. You get me? You get my point? People in Rekubo know me very well, and maybe they are positive about me. But if I just come like this and I tell you I'm a monitor, I'm in the community, we revise all that and we tell them about that, but without any visibility, my dear one and my friend. You know how community members can react. Trust me. you'll be toast.
But the issue, I understand you are 2 monitors in an area, isn't it? If this monitor is not comfortable with this area, you can go to the area where you are comfortable and another monitor goes to another. So you...
Thank you so much. The beauty is that whatever we are presenting is localized to our districts, and our district leaders are here to take action, and what won't probably be done will be escalated to the region and the national level. And I want to appreciate the presentation and all that you have done. Secondly, I also want to echo on the visibility issue. In a way, we can't say it is not important. But as maybe Machot has said, we need to be as much as possible to our local facilities, because there was, at the beginning, there was an orientation, facility orientation, all facilities, and each monitor could go to the facility he or she was assigned. And the facility had all the stakeholders during orientation where the monitors were introduced. So probably if that gap was skipped, there can be an issue. Or maybe there could be another way. However, I don't negate the issue of visibility. If you had a jacket, if you had maybe a tag, if you had maybe an introductory letter from the district introducing to you as a monitor doing this work, yeah, security, as the other person from the ministry mentioned, how secure are you in the community? So I think Mayanja will take it up to see how these are probably introduced to the communities. Last part, mine is advocacy. This part to do with persons with disabilities. At least we have to appreciate that most buildings that are just coming up now have ramps. The capped can, be pushed and can get to the office or even go to the facility. However, we still have some issues that are cutting across. Much as there are these ramps, there is no single latrine that is there for persons with disabilities where they can get support and do the activity. Yes, the ramps are there, but the toilets are out of the budget. So it's a request that henceforth, let's also, as we prioritize the ramps, let's think of where are they going to do, to ease themselves. Even the beds, maternity wards, there are these beds that are specifically for persons with disabilities, especially these disabled. And they can be raised, others can be put down, pushed, but they are not there. So you need to get so-and-so to come lift to put the patient on the bed. And yet, there are beds specifically for persons with disabilities. At least even it can be one bed per facility of this that is user-friendly. This would be very great. I request the duty bearers, I request the leaders to help us during the budgeting process. Please consider this for the better of our persons with disabilities in our communities. Thank you so much.
Yeah, thank you. Let's get one more. I want the one who had not said anything.
Thank you very much, Team Masinjero and all of the presenters. I'm Dr. Wampaviro Godfrey, in for DH Rwanda District. I want us to analyze the issue of CRM monitors being rejected, to dissect it a little bit further. Because one would wonder, other districts are quiet. In my district, for example, we do not have anything of this sort. if the community entry process was followed to the letter, and we have this CRM monitor rejected, there is something that we need to appreciate. In some communities, where, especially which have been participating in research activities, the researchers tend to give some compensation. And if you go to such a community with your questions empty-handed, you may be rejected. And this is where I would request that you go deep and appreciate. Because it's nothing like this is a child of so and so, but it's something to do with their time. Remember, we have had a challenge, one of the challenges about people trying to boycott the study, and maybe because we interview them at the exit, some are tired, some are not willing to participate, but those who are willing to participate, saying that they are rejecting you, there is something more to be admired than what we are just presenting here. And I would request the teams from such areas to go down and try to write some resolution. Not in this room. It may not be solved here. Thank you.
Okay, thank you. Let's get the last one.
Thank you very much. I'm Samuel from Nakola, Kasese. Just like my colleagues have said, CLM project started like a child and it grew up into all the brains of everybody. We began with a series of meetings to introduce the project. We went to every health facility with the monitors, and we introduced the monitors to the health in charges and other staffs. So I also don't know how the issue of rejecting you when we have already introduced you to the health facility, the health in charge, and all the health workers. Maybe something went somehow strange. The issue where we would think about any friction between the health workers is during the feedback meeting. You might find in a health center X, the in charge is the one being talked about as the best absentee. And when you were in the feedback meeting and he's also seated there, other health workers fear to talk about the absentees of the health in charge. I have a health facility where all the health workers left the in charge because he was on a defensive stage. And while other health workers were correcting the situation, when they said, yes, there are some people who don't easily come, and for him he was defending, other staff left. When they left, I told him, do you know what? You are overshadowing the other staff. Can you give them time? And they talk. He agreed, and we recalled back the staff. That was in Hima, I am sorry to say this. That was in Hima Health Center. I told him, no, you were overshadowing others. You were letting them not to talk. So he accepted, and we recalled these people. Then the feedback was okay. However, on the security side also, you need an identification. But this might not come from Mayanja. It might come from Nakola as an organization. In fact, the monitor should ask Nakola Kasese for an identification, because when you get a problem or a challenge in the community, it is me who is the coordinator of the organization that sent you to go and explain whom you are. That issue of identification is at the level of the organization. Then the organization can discuss it with each other. I would think of this. Thank you very much.
Timothy, just 1 minute. I want to clarify this because it's coming from Isinjiro. One, in my own view, I want us to treat this case by case. But this is happened because in Akivale, especially in refugee settlement, we have had a serious restructuring because of funding. That the health in charge, currently, most of them are new, manning the health facility. I remember when the monitor went there, the guy refused. He said, "You are people who are causing us to lose our jobs." So we had to bring in the district. I'm here, my counterparts are here. We solved that. So the issue of rejecting them, it may not be as rejecting them, but there is that kind of negative perception from some health centers. It may not be all, because in Maona we are moving well, in Chairumba we are moving well, but for monitors to be on the safer side, we as the leaders, as the Department of Possibility and Mayanja, we shall sit down and see how we harmonize that. Thank you.
Thank you very much. Let's get the last comment from Betty, and then we can go back to our agenda.
Good evening once again, everyone. Thank you so much, each of you, for the presentation, but I want to echo my voice on what Livingstone, and his second name is Hard, has just said about encouraging and advocating for accessibility of PWDs in these facilities. Remember, all of us here are candidates of disability. We shouldn't be even talking about this. Even sometimes age comes, by the age of 60, or some of us may not be able to talk. We may not be able to access those hospitals. About the issue of communication, what do you think about, all of you are talking about Swahili or you are sharing information, but have you thought about persons with disability, the hearing impaired, the deaf people? What kind of services are we giving out to these people? What kind of information are you giving to them? How do you share that kind of information to people? Can't we learn, for example, we organize and we learn basics in sign language? Mayanja, the director, how about like if your nurses get out with few basics, at least basic communication, but you go to the hospital, for example, myself, and you can't even have a basic talk. Some issues are private and you want to talk to your health worker directly. You don't need an interpreter for confidentiality, but then you have to bring in the issue of an interpreter. So I'm requesting that where it is possible, all of us here, let's try to learn at least the basics in sign language. Because it does not mean that we sit in school and you learn something. No, we can organize and just like 20 minutes, maybe a week, maybe 1 hour a week. But at least we get to know, we know how we can maybe request for history. What is your name? What is your age? When did you start? Things like that, at least which can help and ease the lives of the deaf people. So that is why I'm requesting Mayanja and any other to come in and we do this kind of sensitization and advocacy so that at least all of us, we are at the same pace. But when we talk about communication, yes, we are talking about Swahili, but what of the deaf? Thank you so much.
Thank you very much. Thank you, Betty, for those good comments. Thank you. Let's give a hand clap to the Isingiro team. Thank you very much. And I hope everyone has taken at least one sign language. There is where she said this. I don't know what she was meaning. Let's have comments and remarks. Let's have remarks from Executive Director, who will help to call for us, Kao Kasese, to give closing remarks.
All the best, Timothy. Thank you. Members, thank you for your time. It will take 1 minute to close the session, and I'm calling upon Javira and Peace. Come over. Those who are called, please hurry up, hurry up. Javira, you invited these people. They have been here the whole day. What's next?
Thank you, Doctor. Good evening once again. As a coordinator for the CRM activities and the CIBA activities, I'm very happy that you have showed up today and you have really concentrated up to this hour. I want to thank you and promise that whatever we have discussed here, we shall see a way forwarding it. The issues that we can't handle here, we usually forward them to the next level. For CRM, it's not like we are fault finding, but we are working together to improve. The issue you can't afford, you escalate it to another level. Now, like I have heard the issue from Ntunga more about the people's disabilities, we need an action here. What next? Who is going to address it? If it can be handled at a district level, well and good. If the thing is a ministry, we need to work out a framework to see how we can escalate these issues to the ministry. You saw we have discussed a lot. I don't know whether I can pass through the action. Okay. Then as we are going back, we had prepared some facilitation to the teams. We have the district leaders. We are going to facilitate them with the per diem for 2 nights. Actually, all of us are going to receive a per diem for 2 nights, but at different rates. Yes. And then we are also giving you transport, depending on where you come from, and we have calculated it using the public rates. And for us who are having drivers, the car and the DHO, we shall fund a fuel based on the distance traveled. And we assume that all drivers have already submitted in their receipts and the log sheets. We have log sheet fee so that we can use it as a form of accountability. Otherwise, I think the evening it is already served. That's all I had for you. Thank you.
Thank you. The other issue is, ideally, we should get someone to coordinate a regional forum, regional efforts. And one of you, as a duty bearer, if it was not principles of democracy, would identify, but you are the people to do so. Otherwise, we would put together all what has transpired, put framework to monitor implementation of what you agreed upon based on the time bounds that you suggested. And for those that may not be within your means, that very platform escalates them to national level. Our hope is that we're going to have this done, and then when the national level meeting takes place, we shall certainly, we may not all be at national level, but certainly selected members will represent the region. Javira, I want to give a second of update on that, and then we go to another thing.
Okay, thank you, Doctor. Now that said, take the opportunity. We are going to select a team of 5 people who will work as our regional or steering committee, so that whenever we are called upon at a national level, we can have these teams representing us and forwarding our issues. In case if we have an issue going to the ministry, not all of us will go. We'll have one person represent us at the ministry level so that they can keep on following up. So in less than 5 minutes, we can have 5 names.
I just wanted to, on a procedural matter, we are 6 in number, forward the name of your respective districts, 1 person. The good thing, we are seated in our respective districts. Before we finish and part ways, forward the name of one person who will be on a regional platform that will represent your interests in further steps. I think that's the most democratic and saving our time. We have our daughter, our young staff, daughter in the sense of me as Mayanja, but she's in her own right a staff of MMHF. And as our culture, she's seen everyone coming in, and she's going to see everyone going through and getting out. What are her comments? A vote of thanks.
Good evening to us. My name is Peace Geneva from Mayanja Memorial Hospital Foundation. I would like to extend my appreciations to whoever that has participated in our today's meeting. I would like to extend my appreciations to our project manager, that is Mr. Timothy Tibamanya. Thank you so much. And at the same time, allow me to say thank you to our executive director, Dr. Bernard Mayanja. Thank you so much. And to whoever that has participated today. Thank you so much for coming. Thank you so much for gracing our event. Indeed, we can achieve better and better and better. I end with a simple word. I would like us to take it as a serious note because no one knows how tomorrow will be. But achievement is possible. A good day to you all.
Yeah? You can go back. We must incorporate succession in what we do. We've been on stage for a long time. I think it's time to start thinking of playing other roles, not from front, but in the middle and finally at the back. And I think that's in the same spirit, such as souls are being inspired. Cow, finally, from Kasese, as you come, let me say I'm privileged to have my OB. We ate the Mbara High School posho. We drank the Mbara High School posho. And we sat in the same, not necessarily the same, but in some of these same halls. So the bats and fries, those that still live in Mbara still remember both of us. I'm grateful to be with you in the same room for the same purpose. All the best. Mugumena man.
Thank you very much, Doctor. As he said, he's my OB in Mbara High School. We are together very many years back. Yes, Mayanja Memorial team, of course, with one of my senior colleagues. I cherish when I see you, Augustine. Augustine stand up for recognition. Augustine was my cow one time, and he helped us a lot during that time, Barara and Sinjiro. Thank you very much. And the rest, plus the Minister of Health staff, and the colleagues from local government. I'm Kasager Edward, I'm Cow Kasese, for just 1 month in Kasese. I've been in Rubirizi and in Mbarara. I'm grateful to be part of you today, and I have learned a lot, specifically on issues of CRM. This is a very good initiative, of course. I remember when I was in Chiruhura, rather in Rubirizi, and some of you were here and there. Particularly, I was concerned with the Isinjiro presentation, where I come from as well. And when Madam, the young one, was trying to say, you say rejection, rejection, I said now. With my chair, Ronnie, and my DHO, Edison, that can't happen. When it happens quickly, they know how to manage. They will quickly manage and the rejections will not be there. as you tried to mediate here and there. I thank you, team, specifically the health sector, for trying to help us in the delivery of health services. And this case now, the members, the monitors and the likes, joining the sector and trying to help us in the delivery of health and community services. I mentioned when I was the other side, somebody trying to say cows, cows and the rest. When things such happen, please quickly get to cows and the district chairpersons. We are there. We can come in and quickly resolve on some of the issues. That's why I never wanted to my senior brother to disclose what can be done quickly. But given the roles we do play, I said not disclosing that we shall be there to handle, because we know how to handle and we have been handling. I thank you, team, for organizing this important meeting here. It has been very good, and we have learned a lot, and we pledge as we go back, we shall definitely do our best and make sure those other things and deliveries, health service deliveries are done to the maximum. Thank you, colleagues. You know we are ending at this late hour, but nevertheless, the other one mentioned the per diem. Then you enjoy, but enjoy carefully as you go back to your respective stations. I say bye and wish you safe journey masses as you travel back to your stations. Thank you very much. I officially close the function of today.
Yeah, thank you, Carl. Of course, I'm not speaking, but I request we move outside and have a group photo. Yeah, there is someone there who is going to take us. Kindly ensure that you are in the photo. Yeah, and for our transport and facilitation, you just make sure that your phone is charged and there is network. That is not a problem for Mayanja. Already others have already received the message. Unless if you have a loan there. Even a loan brings the message. Let's move and we get a photo. Then you can come back and pick your items.
Okay, people are following. People. Echali mwenda kwemera. Ahera. Encourage people not to carry bags. Ibage yawe. Kuri mbone cyaha first then mare mbone cyakwe. Nibikiri beshi. Ikintu kihayo jeje. Icyo cyane. Think mine. Okay, people who have been viewing Fatres TV, niko twahikamu hero, mwebale kukuratira omuango yona, mwebale kimwe twabasima nogundo murundi lingera nyenchakare ninga shobundo bwire nabo mutu attention. Okay, abareba Fatres TV mwebale twahika muheru ningashi akuhendera kandi kutukwika akuhendera obuntu batwata tira nazade ningira ngo reka tutamburira mwebare kandi mwebare kimwe na munonga abantu batureba mwebare nanyine wa IT Jean tureba wa IT ngu nawe no wa maigamba n'umukorogo
ni nsima fa Twist TV media kuja hano twatira umukorogo mukora chamani kutambuza information age kwikombantu baburijo no kubamanyisa ti ezendwara zibasa kukorerwaho tutawa Mayanja hamwe na ekitongole cya Ministry of Health na
amazina uriyo hatabakumanya
amazina ganje banyita Beinom Chamiraj nikorana na Mayanja Foundation rishango mbara Kampala Road tukora imiti endwarezi ziroho kandi nibasa kuzitambira bakuratira emitendero yona eshimukwane kuratirwa arupapura ninga babikira aha health facilities zo kwabatiraho ka government ebintu ebikoko ebikozere mugumen muhajira mugumen mikomarwaro mugumen mika health facilities zone omi districts bakabazitire kandi ishaba na mnonga abantu bona bakuturebesha hezi mugume mutukuratira P.2 at Mayanja Uganda na visiting our website mayanjamhf.org.
Okay. Tene namba tokaji bashomera she ya Mayanja njani biruha nankazi
enamba chikuru nokuza platforms zitu ezo zinabagambira at Mayanja at MMHF Uganda na website yitu buri information eroho profile yitu yona nibasajire ahandi nyabaza fa Twist TV oku twatugo mukoro kandi gumene muhagira fa Twist mu following mu liking fa Twist TV a platform zona TikTok X na YouTube channel.
Okay. Inja no mukorogo nano hugura byona
no hibiti
kandi na TikTok byone byona mu bireba TikTok murebe Dr. Mayanja kuko yanagezeho kushobora ogwo mukoro negumanyisaki then mugarice nabo ebyabandi ati nkecho noreba nawe nabona zacanga TikTok
yes
urebe cyari kugambira abantu ni kagambo cyo kugambira iminyeto aka norato ryo minyeto kandi iminyeto niyo gamba ho riri
iminyeto ntigigambaho na wagenda ukareba je nka ikije kubaho gwo musigazo ubwo bisire
ubisiro bira ryo mu
rukundo
abari no mwishi
mazima rukundo mwitisa yifira mu Romeo Konga nishaba eminyeto okwegendesereza no butatwaratwarwa ebintu nkebyo turi no kuguma turi soba no kuguma turi creative nishaba mind ziteka ari creativity no kweya yonke eminyeto abukuba nitwe abantu bamana banchakare mazima batakushanga uri yo mu rukundo nenda kwita yes nicyo konkani imbagambira tugume turi creative turi soba tuyikirizemo push mpaka kikozere because ni manya tugeza aho imirimo teroho konka twaba creative tukakwatagana hamwe abukata umuntu omwe to kamera twatwino kuba twe united nkaba ankeminyeto okwenda kurgayo kuba ikintu cyamane cyanyensya ubu butumwa bwanje mukubasa kaze myeto
okay Laurent tugezeho kugira ngo eminyeto ahari buri munyeta ahuguri tuguhe chance na munonga turi kuba turi ho kugira ngo gwagamba kugira ngo abamwe ni bamarabereba mu ngo babari ignored of which no shoto batukukiri konka tugezeho kureba ngo twakirwanyisa twareba how we can solve this kugira ngo umunyeto nayo yayihura ngo aru Twist TV echo
ne chikora je mnongo konka no bareba umwe wori mbigire byogo muntu okoreba ngo toine muhanda gona no shangu tine cyo kubasa korebwaho kushanga no wasa kurugana ninga kutunga cyo kwenda kutunga konkani mpamya nti twagumatuye kwase na fatwe Steve Nkeji tukareba information Nkejo tukega because na ikomo shonda zona za Uganda tukafunamo ibyo ku
icyo kwega
bakafunamo icyo kwega ni mpamya nti ntuza kwikayo just no kwatagana no kubantu tureba nka fatwe Steve yes ntagwantu nimanya ntuza kwika aha abusinguzi bw'ekintu ekyo so emyeto yona eguma ekwatirira fatwe Steve na no kwatagana na no kwikari abakura batubanzemo because nibo kwa bamanya been experience ubona yibyara biramo de nito tukateka mu ba creativity abakwa ubungo bwitu bukiri buto bitekateka muno kiza abatubanze because atabakoze
yes we can make it just no munyeto ndijo na wari yaha nindeba inebyari munakora oba no mushawo oba niki ija omunyeto gire cyo wagamba akurugire reke kitwatora okay tugezeho kweminyeto amaraka kugira ngo bagamba as long as babona platform kezi ezezamani aha tuyigiteho amazina uriyo
amazina nirakana musi Jupiter akorga rubirizi
yes
ngasire monitor and House of Love Africa
wow so ukachitandika
ekintu ngachitandika
kiri about what kitandikire cyore ko murebi wa fatwe Steve
okay tu kurgo mu June ekintu tukatandika na training tokaza jinja twazum training about how to conduct CRM, how to get information from the community, from the health workers, and again go ahead analyze the data njerito akubasha kuzunzura ikorito kuzunzura how to analyze that data, then after analyzing that data you give feedback to the community. Then you give also from the community, you give feedback to health workers. From health workers, you go to the district level. From the district level, now we are here at the regional level. Then from the regional level, you proceed to a national level. Yeah.
Atecho, muchitandika muta, who mobilized you to start that kunganya information? Tuenda mbweno gambiro munyeto ryoko kugira ngo in case haronka chance na ari kubasa kuchitandika ninga kuchijoininga mukachitandika muri yabashahu muri abantu ba IT nkoko mugenzi wanje nkoko hari muri kitandikiraho kugira ngo umuntu amanye iki kintu we nakijoininga atoryo akano shoot you are well paid.
It's not like that. Okay, ekintu kachitandika kurga omuCBO zitu.
Okay, evina byabyaro.
Okay. Ebikubambere birira efuzi na nabantu abakutwana ku kasirimu abakufuna oburemezo mu magara gabo bakubeya na TB. So akarho mukutandika je munonga tukatandikira district level kwegitana nebyo bina bakachuzingamu abantu abararonde information nurse data ekurga umbantu umarwaro then kurga district aho nho basitandikire kurunda ba monitors bakabine baronda bakurga umbyaro communities marwaro izigaro mu yes so kwenda kugira ngo wano gambe kintu if let's say bagamba kugira ngo abashaho nanka irwaro ngecho kurebero irwaro nanka kiyemba jirangu abashaho tubaruho kubemba jango abashaho tubaruho iwe nko muntu akubero muri je community have you ever experienced that warachisanjire waragire nka irwaro ukashanga ngo byadaradara abashaho tubaruho so that is the main reason kugira ngo yasinjire kugira ngo bakwate abantu baronda bo mu communities kugira ngo nano muntu yanahereza evidence yanagambe kintu ebe noreba nkwenyini you can really relate to the community so ekintu kyona kikwasira ari communities kugira ngo turyabashaho. Me personally, I'm not a musawa, I'm a statistician by profession. So conducting data, I deal with data.
You deal with data.
I deal with data.
Of which it is for every district.
Of which it is for every district.
Kokiwe nori ukargayo wache creatingira. Watandaka.
Yes.
Hato bonyona nimfa omuntu ryoko nko munyeto. Amanyengo nawe nabasa kutandika kantu ako kana wabenkiwe. Bana bashomere baryoko konkatine kweyambo kwa mani hata nico nagezo kubuza nkati ko munyambaro ryaho munyeto ryoko na kitanu wetino wakumobilizing. Is there anyone who mobilized you?
Yeah, bakatumobilizing because it was through that district meeting. Kubarjura district meeting bineroz CBOs nada se bevine bikubera mbyaro mu communities no babemba choosingera umuntu akubasa kora ki kubasa kubana abasha kufunejo information akakidisseminatinga ikigarike kikankahi umba decision makers to make an impact kugira ngo we hold duty bearers accountable for their decision that they take. Purpose yo jiona CRM yona eria kugira ngo we breach the gap. Think mamuri nyankore. Phrasing ingabata kugira ngo we breach the gap.
Mugiteho
umwanya gugwagati a service abantu abakwiza amarwaro kufuna service na nabantu abakwereza service. In the whole of this process CRM abantu ebakora bamu babizera amarwaro biruho chonka inengere itukubasa itkumisinga wota baburiza abantu then na nabantu abasaho abakwereza obuhereza. They also have challenges they go through. Chonka nabo they have nowhere to talk to. Chonka CRM hata ije tuyamba okigamba no murwire yakujangu this and this facility tuine kizubunanka nanka ogendo yikomushaho omushaho chugambera ombuze chonka kana hureki abarwire ne bangambira they have this challenge. Hati niwo garuko muhereza feedback yargankai
yarugomba
na hata koraki akugambira hawe eti oburemezo bwayine. So echo kiza kituyamba nkahi kituyamba kugira ngo directly wagamba nabantu abizera facility bakufuna obuhereza facility then again wagaruka wagamba nabakuhereza obuhereza then mufuna solution. You come into one conclusion mufuna ekintu ekichumu ebyo kushanga ngo tebakubasa obitwara head of which nchibasha kuba too hard kusanga nkaherete waka na argankaho nazo nko wa DH we have this challenge. Some things you take them to be minor but they affect service delivery. Yes. So ngatko kuba we itawa kwa bari mu community twabisoroza nkebyo we bring them together. You see the argument which was here. Wabereta together then hata nabo bafunachi bafuna solution. They know the people they are serving, they hear the beneficial part of the people they are serving and they hear the challenging part of the people they are serving.
Ninjira ine chiwaye gomuri yo gomuntu akitandikira kantu. Have you picked a point? Wachireba akitandikira umurumu. After starting a job hata nawe no wari ku benefiting. Of course hata wawura unaza kubona ni PDM niki per diem. You are going to get your per diem.
Abantu nkabo.
Yeah.
Tuenke kitongo cha Mayanja MMHF abantu ba irakagito uko hita kwika because barya base nibasa kwikari abantu bitakwikaho. So aba bantu bakora umwuga muhango omu project yito gituku yo kurwanisa malaria na TB omu southwestern region. So the CBOs aba community led nkerizo ba meeting kwiyeri abantu mbayamba nti irakaria government kurgeruguru rikahansi twikahihi n'abantu oruzito ntwatari konka abantu baba ambassadors bitu. So nugo ni msima na nabandi CBOs bona batahibe akora umurimo wo murungi because kine impact y'amani kikora aha abintu by'amagaro mu Uganda na no mu South Western region okwatira mbyo na Ministry of Health. So ni msima mnonga agwa umurimo gwe na we nko musigazi ko munyeto uko yikirizamu akasharamu ikizubu kitu eminyeto tukusharamu ntwa twina ideas okamanya ngo hacyagwa nto nyongere mu biringo okamanya ngo hacyagwa nto nyongere mu biringo tokayongera mu misho. So ni njiraba amnyeto eshema kwa neyikirizamu ekasharamu hatati kantandike nkore kintu eki ninkikirizamo kisa kunkora kandi nko gumusigazi kuyagamba ko yiyama katandike kintu cyatankiraho hati nana kominta hari
kana wa benefit
ingiremo nkerizo kuya benefit
umubuza aine challenge yone yarebere have you faced any challenge in what you are doing?
Me personally, I can say oba kurugira abembera yanje communication and
eba begise mbwenu
eba twegise yeah over times it is someone is per yeah over times it is someone is per we call them traits
obuna bagweta batomurnya
characteristics of
traits ni nkachi how do you call traits
imbera y'umuntu obuhanga bwe yes so omukurugira nko me interacting with people tikangume
okay yeah
cause wareba challenge yo kugira ngo ipa baremereza mukore imirimo yabo but me personally throughout all the facilities I've gone to challenges zo kubgana there are these natural challenges zo kusanga ngo distance nini ingwari yo mucucu umucucu mwinje nguto nimbi enjora yakutangira yo to kurgayo those are but kujangu you have gone to the facility ngo ya ine challenges zo kujangu challenges zo kugira ngo mbusimanyi bakubinga because of your exposure no
so iwo mundeba yawe ece kintu cyo wayitandikire nko muntu urebere ngo wakimana mu bwire buri kwingana kikanda how have you benefited from it besides that bituru kureba katude ushanga nobona za naka pa DM besides evyo binde nebi
actually I will not go much on money ndagende munonga say
of course
but you know in life no building steps
yeah
because right now me in terms of money I will not touch it in that chigambo
of course
unkanza kuchigamba nariga when I move here nkarganga za district I will not face challenges kujangu which office should I enter to yenye ipsinanka na benefit yambere kujangu nawe na exposure interacting with the district team moving here I can't get difficulties. So in terms of money, yeah, there are some things we have achieved. The personal life can improve. We get some kagot at home. If we are selecting mu training nafuna yo buzinga bubiri bukutandikiraho yes so in terms of that cyonga nyowe ninkirebera munonga kugira ngo sente teach cool for now but building a pass ahora arabe tomorrow ncho chikuru yes ncho that is my aim and my target
nko munyeto mbwenu for sure building of starting something and korebe bintu ubonamo na hatora umuntu ubona kandi wacitandikire I think there you need to thank God
and for now it is I can thank God that I'm going for another position in local government if everything goes well it is my prayer anytime if everything goes well it is a prayer anytime to the local government.
Local government
as a CDO. Community development.
Ako ije no bireba utandikire mbera ya wamura hati goro yeye niyo kuba CDO.
Nchironji nko munyeto kushanga naro aine that goal naenda ku achieving because umwe tukusetinga ibintu akwani bagira ngo what aiming for umushana ningo mwezi umushana what aiming kushutinga umushana toka hitting umwezi akwani wasa aiming ikintu cyangu no kushanga na local government na arrangera konka no shanga yika aho yanagamba CDO njigambira
nanechi ndekabanza
neshindi nkabona chance for first CRM first phase first semester I got a chance in representing on the national level on compiling data.
Okay, in compiling data.
Me, in whatever I'm doing for now, I'm not looking at the mere money. Yes, the mere money can make you to improve yourself, but a pass. Where to go tomorrow? How are you going to reach your target? What you are aiming for?
Okay,
that is my
okay, thank you. That's why we always twahika minyeto umwanya gwagura umuko munyeto ntumweta kugira ngo tumuhe platform shana mu manyengu twarebaho na team ni kwa kweyeta team atwira friend wanje konkeza yare musinja mwana mureba narabarabamo of which we wish him well abakazo you know that gentleman no yangu achar vize na ninku mbaretera ho kace ashanko wabatera mukace mumureba okay koka ijo bagambe kigambo kimwe ninga bibiri as we wind up reka tumushike ikirungi kamera zitu nizireba thank you team tukunda munonga tugamba kace aramusa abantu then chete
abanka
bona abantu bareba ba Fatres TV.
Okay, good evening. I greet you, Fatres TV viewers and subscribers. I'm Timothy Twamanya. I work for Mayanja Memorial Hospital Foundation as the programs manager. Happy to be here for today, and I wish you all the best.
Yeah, we were mnono. Azo ryo mushije manzi yamani. Okay, abareba Fatres TV owaria kamera ya Faisal kakoza then na nyomo wanatambuza umurumo kureba ngo buri kimwe cyona kigenda clear abantu batureba mwe bare mugumize muri mutureba nora tugezeho kureta sectors no twakumara twamarira ushanga twareta mwari hura Dr. Mayanja byanagamba kandi nebyamuheru byona nebugambo birungi kandi birungi na neco mwe bare munonga ikikurito cyanyu muza Facebook muza TikTok ningira ati buri story yo na TikTok yagireyo Instagram YouTube yeruho hatera live twagira twaragaho tunoza kushanga buri kimwe cyona buri kimwe cyatambuye ikikurito mutwe businesses ninga shimutwete oyo no mukoro gwawe oyo no maybe waferwa toriyo oyo ne kigambo kirungi okugira ngo ino byogambira yihanga bantumwe mutukuratere then sima munonga naho nareho Erika Ruhanga ngo yaruho yatugamba ngo yanareba function yona yambarira kano shoti Dr. Mayanja namanya munonga mwebare no bundo bwire